Hello everyone, today we are going to talk about mouth and esophagus. So as you all know, mouth is the entry point of the gastrointestinal tract and is responsible for the mechanical digestion as well as chemical signaling. So we secrete about 1.5 liters of saliva daily, and saliva is secreted as acidic solution at first, and then due to ductal cells, sodium and chlorine are extracted while potassium is given. So it becomes hypotonic when it is near the lumen. So this is how the salivary ductal cells work. Sodium is taken and H plus is given out, and chloride ions are taken and bicarbonate ions are given, and potassium plus is given. So here you can see H plus is given and then again taken, while there's net outflow of HCO3 minus from the salivary ductal cells. So volume generated is massive, 1.5 liters per day. So these cells, called as sinus cells, they secrete primary isotonic fluid resembling plasma. Ductal cells are filters. They actively reabsorb sodium and chlorine in exchange for potassium plus and bicarbonate. Ductal cells are water impermeable, so water can't move through ductal cells. So if you think about the flow rate versus the composition, if the flow rate is low, tons of time is there for reabsorption. So saliva is hypotonic, highly hypotonic, and low sodium and chloride. If it is fast, if the flow rate is high, the fluid rushes fast duct cells and less time is there for reabsorption. So it is closer to plasma levels. If they can't reabsorb sodium and chloride, then it is basically not hypotonic, but it is closer to plasma level. But bicarbonate always increases at high flow rate because parasympathetics actively stimulate its secretion. And if we talk about the saliva secretion, there are three glands: parotid gland, and sublingual gland, and submandibular gland. So the parotid gland, it secretes about 20% of saliva and it is watery. The parotid gland, it secretes watery saliva, while the sublingual gland, it secretes viscous saliva, that means more mucus. And parotid gland secretes about 20% of saliva, while sublingual secrete about 5%, while submandibular secrete about 7%. So mandibular is like middle in between serous and viscous. So bicarbonate has the buffering capacity that will avoid damage during reflux. And also saliva helps in lubrication and protection via mucus, and protection via antimicrobial enzymes, and sensation of taste, gustation, because there are taste buds, and salt taste via anaerobic receptors, while sweet, bitter, and umami taste via metabotropic receptors. And this is regulated via the autonomic nervous system. So smell, sight of food will increase, while fear, anxiety, sleep will decrease. The saliva secretion, because it affects salivatory nucleus in medulla, and parasympathetic will go and affect the otic ganglion to stimulate parotid gland, while submandibular ganglion will affect the submandibular gland. So if we talk about tails transduction, so as I told, inotropic salt can sow tails is due to inotropic, so sodium plus influx, and sow tails is due to protons enter via these channels. And metabotropic ones are G protein coupled receptors. So if we talk about the autonomic salivary reflex arc, so parasympathetic, submandibular, and otic, and then M3 receptors will secrete acetylcholine that will act on M3 muscarinic receptors that will cause watery saliva. So during parasympathetic, it will secrete more watery saliva, while sympathetic, it activates through superior cervical ganglion that will produce thick mucus. So the glossopharyngeal is the 9th cranial nerve that will act to the submandibular or sublingular, while the 7th cranial nerve, that is facial, it will act to the parotid glands. And sympathetic, T1 to T3, superior cervical, so it will secrete norepinephrine, and G protein coupled receptor, GS coupled, beta adrenergic, so CAMP, PKA, and protein synthesis and exocytosis of mucous granules, while the muscarinic receptors will activate PIP2, phospholipase C, and then it will break down PIP2 into PIP3, which will go and stimulate or like release CA2 plus from the endoplasmic reticulum, and this will open Cl- channels that will make this saliva watery. So here you can see how the superior salivary nucleus and inferior salivary nucleus. So superior salivary nucleus will salivatory nucleus will it controls the submandibular and sublingual glands, while inferior one controls the parotid. While the taste reception goes via the glossopharyngeal nerve as well to the tractus solitarius nucleus. So here you can see different receptors are there for different tails, and so calcium plus have a great effect on the volume of the acinar secretion. Parasympathetic, the agonists that increase calcium 2 plus have a great effect on the volume of acinar secretion, which an agonist that increase the intracellular CAMP increase the enzyme and mucus content of saliva. Sympathetic. So here you can see how it works, right? So here this pathway, the parasympathetic pathway, secreted calcium 2 plus, while the sympathetic pathway secreted CAMP or produced CAMP. So here this produce mucus viscous one, while this produce serous saliva. And then it is about the reflex, the swallowing reflex. So first part is voluntary, and second part is involuntary, and third part is also involuntary. So voluntary one is done when tongue compresses the bolus against the hard phalanx, and the bolus goes to the oropharynx. After the oropharynx onwards, it is involuntary because touch receptors in the pharynx get stimulated, So the glotopharyngeal vagal and trigeminal nerves will send impulses to medulla and pons, and then it will send motor impulses via cranial nerves to control the involuntary process. So the breathing will get interrupted while the soft palate is elevated close in the nasopharynx. So breathing will be just pushed for a little while. So tongue pushes against the hard palate, and epiglottis covers the glottis. Soft palate flips holes in the nasal cavity, and cartilages around the larynx are also constricted. When all openings are closed, a wave of muscular contractions pushes the bowels towards the esophagus. And then in the esophagus, the vagal stretch receptors will get stimulated, and it induces a wave of contraction that is called primary peristalsis, which is the speed is about 3 to 5 centimeters per second. So it is known as the vagovagal reflex. And then it reaches the lower esophageal sphincter, and sometimes the process known as secondary peristalsis occurs to remove any remaining food in the esophagus. So when the wave goes to the lower esophageal sphincter, it will open to allow food bolus to pass into the stomach. So the pharyngeal and oral propulsive phases are brief. So weakness of the tongue or any other neurologic disabilities will affect the oral phase. So if we talk about the esophagus has different sorts of muscles. So first part is basically striated, and the middle part is mixed, while the lower part is smooth. So here we can see the middle part of the esophagus. We can see the striated muscles and smooth muscles as well. So here you can see smooth muscles like two different ways. So this is the long section, that's why you can see like spindle shaped, while the smooth muscle cross section is like this, and striated you can see like this. So this is the top part. So we can see this is the striated muscles, cross section, and the longitudinal section, while the lower part we can see the smooth muscle layer. And this is serosa, that means it is obvious that this is the lower part. So esophageal lower sphincter is also made up of smooth muscles, and how it relaxes is due to the vagal inhibitor neurons that release nitric oxide and vasoactive intestinal peptide. And lower 1/3, the smooth muscles that are controlled by autonomic vagal fibers, synapsing in the orbits flexus. And the upper 1/3 is striated skeletal, that is controlled via the somatic vagal fibers from nucleus ambicus. So during inspiration, intragastric pressure increases and the intraesophageal pressure decreases. So yeah, obviously the intragastric pressure should increase so that the sphincter will not open. But not sphincter will open. So tendency to reflex move. Contraction of the crural diaphragm during inspiration increase, so that the esophagastric junction pressure preventing reflux. So if there's a problem in this crura in the diaphragm, there will be reflux. But due to this pressure increasement in the esophagogastric junction, due to this diaphragm, the crural diaphragm, it will prevent reflux. So the striated muscles are innervated by motor nerves in vagus, and smooth muscles by the autonomic innervation via parasympathetic and sympathetic. So if we talk about the clinical pathology of the esophagus, so esophageal atalasia, that is selective loss of postganglionic inhibitory neurons in the oesophagus plexus. That will result in lower esophageal sphincter to relax upon swallowing. So that means if it can't reflex, there will be like, we can see a bird beak like thing. So this happens due to partial loss of neurons, and this causes this kind of thing. And also difficulty in swallowing happen, as well as lung infection by accidentally inhaling oral gastric content. While the gastroesophageal reflux is due to incompetent lower esophageal sphincter. That is that it doesn't relax, or it relaxes not completely. So it causes mucosal injury, heartburn, and metaplasia might might grow. That means the squamous cells will get replaced by columnar cells which are acid resistant. So that is called Barrett's esophagus, squamous to columnar, and there's a cancer risk in this. And aspiration pneumonia is a failure of airway protection during pharyngeal space. So this is mainly in patients having dementia and other sort of neurological diseases. So in order to check for diseases, we can use esophageal manometry. So this shows the pressure differences for the doctors to investigate the disease.